Well, for many years we only had one real option, that was warfarin, and over the past couple years we have added to that armamentarium, and now we currently have 4 drugs that are approved. They're technically better drugs than warfarin. Warfarin is a very difficult drug to use because it has many drug-drug interactions and also has interactions with food, which is very rare for many drugs that we use. So patients have had a tough time having a good level. And unfortunately, you need to be in a very narrow therapeutic range in order to get the benefits without getting the complications associated with it. So these drugs are much more easy to use, but quite honestly, we don't have the experience with them as we do with warfarin that's really been around for more than 40 years ago. And yes, they're relatively new. A couple have been out now for 2 or 3 years, so we're certainly getting that experience. And there are very large studies with each of the drugs that showed a significant benefit compared to warfarin. These drugs are either the direct thrombin inhibitors or the factor Xa inhibitors. They're the ones that people see lots of commercials about on television for stroke prevention and atrial fibrillation. So it has been a nice thing in a way because it has raised public awareness of the risk of stroke for people who have atrial fibrillation, because really they've bombarded the media with that. Not everyone who has atrial fibrillation needs to be on anticoagulation, although we're learning that more and more patients do. What you need to do is kind of see the right drug for the right patients. These drugs are not at all approved, the newer ones, for patients who have valvular heart disease and atrial fibrillation. So that's a reasonable subset of patients. If you have a prosthetic valve or significant valvular abnormalities, you should not use these drugs because some studies have shown that they're much worse than warfarin in that sense. So you have to choose your patients correctly. Also, they're excreted for the most part by the kidneys, so if you have some degree of renal insufficiency, that's not ideal. And most interestingly, the newest drugs, the edoxaban, actually if your kidney function is too good, you're not a candidate for it either. So that's going to be one of the nuances of the newer drug. Stroke is the most devastating complication of atrial fibrillation, and these drugs, along with warfarin, are very good agents in helping to prevent strokes in patients with atrial fibrillation. And even the patient that does have a stroke while on an anticoagulant, they're not 100% effective. The strokes are usually of much less severity and often quite a bit more reversible, which is obviously a good thing. Well, I mean, we'll see what the future holds. I mean, very often when a new class of drugs comes out, the very first agents are maybe not be the total best ones, although they do seem to be, pretty good already as far as in their efficacy and safety. Again, and used in the right patient population. And it's not that everyone needs to start warfarin now. We do start many patients on the newer agent if they come in with new onset atrial fibrillation. They don't want to be bothered by getting their INRs checked, and their insurance covers it. These newer agents are quite a bit more expensive, so you do need to, warfarin is a generic drug, so you have to take that into account with your patients as well.